Thanks everybody for being here today. It's a wonderful Monday in Oregon. It's sunny and going to be warm for a week. I can't believe it, and dry. This doesn't happen here. But very excited to have everybody here today. And I would like to welcome Sarah from the Partnership to Improve Patient Care. She's one of our other panelists today. Sarah and I have had the pleasure of working together since early 2000s. It's kind of scary. Um, and she's a fantastic advocate. For those of you who don't know Sarah, she is the go-to for questions and answers. So I'm very excited to have Sarah on board today. We are going to talk about the process and what's happening in Oregon with the PDAB, but this is being used. PDABs are listening to each other. So everything that we talk about today really kind of goes for almost all the PDABs. They're all different, but patient voice, the one thing they're not different in is that the patient voice needs to be heard and is not being heard. And so that's up to us to change that. And this isn't a knock on PDABs. It's just that it's really important that they are hearing from patients because they're making decisions that will affect everyone. As an example, the Colorado PDAB just used the Oregon report in their cost benefit analysis. They used two paragraphs over and over and over again, basically saying they don't know what's going to happen, but using the report from Oregon and the language right out of that report. So what happens in Oregon does not stay in Oregon. So I'm glad everybody's here from all over the country and is ready to, have a conversation about this and how we can make sure that the patient voice is heard in the PDABs. We're going to talk about the role of the PDABs, and Sarah's going to take that on. Then I'm going to talk to you about the current drug list and what's up for review. And we'll talk about the patient caregiver question. And Madonna's going to join us to how you can provide input to PDAB and your state legislators. Sarah, why don't you take it away with the role of the Prescription Drug Affordability Board?
So Sarah Van Gertrude, I'm the executive director of the Partnership to Improve Patient Care, which is a coalition that is led by former Congressman Tony Coelho, who, if you're familiar with the name, it's because Tony was the person who led the Americans with Disabilities Act when it was introduced. He was the original author. So as you can imagine, these issues are kind of near and dear to his heart. He is also a patient with epilepsy, which is the perspective that he brings to this discussion. And I met Lauren, just as a little background, a million years ago when I was working on Capitol Hill for a senator from Louisiana, Senator John Breaux. And Lauren, I love to tell the story about how, when people go to the Hill and they meet with these staffers who are super young and they think don't know anything, I'm like, I too was one of those staffers that was once very young and had to be educated. And so Lauren was one of the wonderful people that came in and educated me a lot on hepatitis issues in particular. So anyway, I always have very much appreciated that. I had a lot to learn. But, so here we are. And, now I'm still working in this world and enjoying it a lot, but I will say it's gotten a lot more complicated. So you want to move to the next slide. We'll get into the meat of it. So in Oregon's a state that we actually have watched really, really closely at PIPC. While we originated as a coalition to support the creation of the Patient-Centered Outcomes Research Institute with the goal of everything being patient-centered. We wanted patients at the seat at the table and everything that was being done, both from a research and policy standpoint. Within the PCORI statute, when it was passed as part of the Affordable Care Act, there was a provision that barred the use of quality adjusted life years, which is a measure that's discriminatory and we'll talk about. But what's interesting is that this all kind of actually started in Oregon. Back in 1990, the Americans with Disabilities Act passed. In 1992, Oregon was the state that was flagged. You had your original Medicaid waiver was submitted, and the secretary at the time under Bush said no. And they denied the waiver because of the use of quality adjusted life years as the measure for determining the prioritized list of services. Now, of course, we came to find out that those measures were kind of brought back into use, and now Oregon is not using them. But anyway, it's been a process in Oregon. But the good news is that you did pass a law in response to all of this recently that, at least hypothetically, bars the use of quality adjusted life years. Um, and that, but it's been this whole process in Oregon, I guess, has been a little confusing to us because first you had the PDAB pass with this language that's up on your slide. It says the board may not use quality adjusted life years or similar measures that take into account a patient's age or severity of illness. But the way it's worded, it says to identify subpopulations, right? When this was originally going through, because we were working a lot with some of the advocates in Oregon on it, and it was being pitched to them as a quality ban, right? Now we're learning that it's not really a quality ban. But then Oregon passed the law banning qualities in last year, which seems to be more clear. And that law governs the provision of and payments for health services and medical assistance. But then we're hearing from the board that they don't think that this law applies to them. So I think it's just been a very confusing process in Oregon. And I think that's why the advocacy is really important because not only do you have the federal laws that we'll talk about that govern these issues, but you actually have state laws that govern these issues, which a lot of states don't have. And yet it still seems to be a problem. Next slide. So the quality adjusted life year, just as a little level set, and I'm sorry if y'all have heard me talk about this before because I talk about it a lot. The quality adjusted life year is a measure that is used in cost effectiveness studies that the disability community has been fighting their use for over 30 years. Basically, in this complicated calculation and formula, a 1 is perfect health, a 0 is death. Most people who have some sort of disability or chronic disease will fall somewhere in the middle. Next slide. And so what that means is that when you calculate the quality adjusted life year and what something is worth in terms of how, so you might say, okay, well, we're going to get this many life years out of this treatment, but the how many life years is considered 0.5, for example. Let's use the MS one because it's an easier calculation. Somebody with MS their lives would be considered worth half of somebody who is maybe younger, has optimal health. And then the other thing that when you look at the quality that it's measuring, right, is okay, so say somebody is at this 0.5, where will they go on treatment? Will they have a quality of life that improves to a 0.6 or a 0.7, so a 0.1 or a 0.2? Maybe they go up in terms of quality of life. Will we value the thing that takes you from a 0.8 to a 1 as much as we do something that takes you from a 0.2 to a 0.4? So like the more super disabling types of conditions. I think this is where the measure gets caught up in being not very reflective of what people value, and it becomes a real problem. So next slide. So what you hear about a lot, and the reason that I think the Oregon PDAB and other PDABs and the federal government, like you're here, when we talk about quality adjusted life years, we're seeing this caveat that we'll say we can't discriminate in life extension, right? But the challenge is that so while the quality itself does explicitly discriminate in the context of life extension by valuing those lives at half of optimal life, say, there are bigger problems with the quality than just that, right? The incremental health improvement piece that I was talking about earlier is also a problem. And it's not just a problem for the quality adjusted life year, but it's also a problem for this measure called the equal value of life year gained, which is a measure that is also used alongside the quality in studies that are conducted by the Institute for Clinical and Economic Review, which is the primary source of, I would say, in this country, of data that is based on qualities. And they do a lot of cost effectiveness type studies, particularly on new drugs that are coming to market. We've expressed this concern to ICER. their goal is to try to be as influential as possible in these processes, and haven't been particularly responsive to the disability community that doesn't like the implications of their use of these QALYs and EVLYGs. So it doesn't really translate the clinical outcomes into these what we call utility scores. So you also say, you're trying to figure out if you're going to take somebody from a 0.5 to a 0.7 in terms of their adjusted life year. Well, what information is going into that? There's a health utility measure called the EQ5D. The EQ5D would really just talks about mild, moderate, severe illness. For most people, they don't define their condition in those terms, right? They're thinking about their condition in a much more nuanced way. So there's a lot of lost information in these calculations that go into these measures. You also have just that people attach different values to their own health states than the general public. Ari Neiman, if any of you are familiar with that name, he did a really terrific study back right during COVID when the crisis standards of care issue was percolating. And he looked at public surveys of basically who should get the ventilator in a shortage, right? And what he found was that there's a tremendous amount of public bias against people with disabilities, where people will say that the quality of life of people with disabilities is less worth saving than other lives, right? So there's a lot of bias that goes into these public surveys in terms of how they think about disability and the value of life they attribute to it. There's a lot of evidence, but Ari's study always comes to mind first for me. And then, value assessment, as we all know, just in the context of research, right? It takes years for research to make it into practice, right? So these clinicians that are trying to treat patients often know more about what the impact will be on a subset of patients than the research literature will necessarily reflect. And yet we find ourselves relying on these value assessments to determine what kind of care people get in terms of what's covered by payers. Next slide. So I think, when all of this kind of gets into the PDAB, I think for patients, right, the big issue is, what does this mean for me? And I think the challenge that PDABs are facing and the questions that they're getting asked and they don't have great answers is what's going to be the implication for patients in terms of their own costs. If you're relying on these types of cost effectiveness studies then to set upper payment limits, well, what do you do when they are those studies themselves are discriminatory, right? They devalue people with disabilities, chronic conditions, say older adults who have fewer life years left. And then that information and those prices or the value that they're attributing to these treatments is then translated into where payers will put things on their formulary, what kinds of utilization management strategies they may use. And so in other countries, other countries actually came up, but the quality was not created in America, right? This was explicitly a measure created in European countries for the purpose of rationing care. So that is what the quality was created for and is used for. And yet we find in these other countries where they rely on these measures that they tend to provide less access, fewer options for patients, and slower access, especially to these new and novel treatments. So, anyway, I think, it becomes an issue if we're I think worried about how we are essentially importing those ideas and that tendency towards rationing care here. Next slide. Anyway, this is a very long slide, but the point of this slide is that a lot of expert people have come out and said qualities discriminate, the equal value life year gain discriminates. A lot of these quotes came from the process of setting the new rules for Section 504 of the Rehabilitation Act, which is the law that passed in 1973 that bars disability discrimination in healthcare programs. And so it's not just the quality adjusted life year that folks have a problem with. The equal value life year gained is also a similar problem. And yet the Oregon PDAB has made a statement, has publicly stated that they think that the equal value life year gained is perfectly fine and perfectly legal for them to be using. Next slide. And so this just kind of goes through some of the history, right? This is not a new issue. It's fascinating to me that a lot of times when you hear these discussions happening in the PDAB, they often talk about it like it's new, like it's something that's never come up before, and it's this made up thing that we all, anyway, this is not new. The issue of QALYs has been a roaring issue for a long, long time. So, I mean, like I said, the Rehab Act passed in 1973, the ADA in 1990. There was enforcement against the use of QALYs in 92. Then you had it reinforced in the Affordable Care Act and a ban on the use of quality adjusted life years in Medicare. And then in the Inflation Reduction Act, which passed in 22, there was an explicit ban on the use of QALYs in the drug negotiation process. Again, in 24, the House at least passed a QALY ban that would extend from not just being a ban in Medicare, but across federal programs. And then Oregon passed a bill. And then last year, we had all the new rules that came down the pike, the civil rights rules for both Section 1557 of the Affordable Care Act and the 504 rules. So this is not new, is the point of this slide. Next slide. So this is becoming also an issue because nationally, so the Section 504 rules that passed, that got created last year, right? Section 504 is the federal law. Those rules hadn't been updated in 40 years or 40 plus years. It was time for them to get upped. It was a big deal when we got the new rules. They were finalized in the Biden administration. But keep in mind, like they were finalized in the Biden administration, but this process actually started in the last Trump administration. Roger Severino, who was at the time the director of the Office for Civil Rights, when we were going through this issue in COVID with states creating crisis standards of care that would have essentially put people with disabilities at the back of the line for a ventilator, Roger Severino came at this from the perspective of all lives have value. He actually partnered with the disability community to fight those states that had those standards, and was very much in agreement with us that measures like quality adjusted life years had no place in federal policy. So he actually had been pushing for these kinds of rules when he was leading the Office for Civil Rights back in 2020. The rules eventually got finalized just last year. We are very concerned, though, that now, though there is litigation in the states from several governors, particularly in southern red states, against the 504 rules, there's a big effort in the disability community to get that legislation dropped. But that is a threat to Section 504. They're actually arguing that the statute itself is unconstitutional. We also don't know what's going to happen from an administration standpoint with the new rules, whether they will keep them or start over. We're also similarly concerned that even though CMS acknowledged that they're barred from using QALYs, that there were several QALY-based studies included in the explanations that they used for how they came to these prices that they got to in the Medicare negotiation program. And we know that ICER is pushing the equal value life year gained as a quality alternative. They've been very explicit in what they have sent over to CMS on that. And we're certainly hearing that come out of PDABs across the country. So it's a long way of saying, right? Laws are only as good as the paper they're written on if they're not enforced. So I think, part of this process, in addition to the advocacy, is at some point, I think really pushing for enforcement of the laws that are already on the books. Next slide. But in an effort to be consistent, we still want this Protecting Healthcare for All Patients Act, which is the bill that passed the House last year, but never made it through the Senate. We are really hoping that it gets reintroduced soon. The challenge with that bill is that it's had Republican support and needs Democratic support as well. And the Biden administration didn't really oppose it, so we're hopeful we can get there. So that's just an overview of sort of some of the issues and the ways that Pipsy comes to these issues and when we're talking about PDABs. But I know Lauren and Madonna are going to have a lot more information that is more specific to Oregon. Thank you.
Thank you, Sarah. We will definitely open this up for questions afterwards. So if you have any questions, you can throw them in the chat and we'll make sure we get to them, or afterwards we'll open it up and talk about it. So I wanted to talk a little bit about just the drugs that are under review. You know, when they put out the list, they had the class of drugs, and I really didn't understand the depth of the diseases that are affected by this drug list. And um, I really hope there aren't very many young women in Oregon, because migraine products are really going to take a hit if they do this. I mean, look at every one of these migraine products that are on here. And then Botox obviously has other Botox has other diseases that it's used for as well. But then breast cancer, and when we talk about breast cancer and you think about what is the cost of your drug, all of these breast cancer drugs are taken in combination with another drug, and so to figure out your cost for that. Not to mention, these are really specific breast cancer drugs for metastatic cancer. Um, I cannot believe that we're even talking about what the value is of these drugs. For a woman with breast cancer, it's needed. I mean, this should not be a conversation. Um, the number of diabetes drugs that are on here, every one of them, I hope you don't have type 2 diabetes. Um, hope you don't have psoriasis in Oregon. I mean, look at this list. And every kind of psoriasis and any kind of arthritis. It really is amazing. And again, so many of these drugs are taken at different amounts, different times, you take two once, you have two injections at once, and then you take it every 6 months, or depending on your drug, you may take it every 3 months. It's really hard to figure out what you're paying per month for some of these drugs that are on these lists. I was looking at the FDA indications for all of these, and it's very confusing. Um, but Crohn's disease. I almost lost my best friend to Crohn's disease. It's very rare to get diagnosed with Crohn's disease immediately, and when you do, and you finally find the drug that works for you, let's hope that our states don't take that away from people. Great article. I put it at the end of this webinar and the resources. Great article came out today from Maryland about another woman that has Crohn's disease, and talking about the Maryland PDAB and the effect that may have on her. And asthma, COPD, heart failure, MS, Ocrevus. This is an infusion that's taken with other drugs as well. So again, do you include your doctor's office visit when you have to go have an infusion? Is that part of the cost of your drug, or is that, I mean, how do people really take all of these different things and look at what's the cost of it? Schizophrenia. Are we really gonna debate schizophrenia drugs? If it works for someone, it works. It really is. I'm shocked at what these drugs do, and HIV drugs, AFib drugs. I mean, these are important drugs that people take, and it shouldn't be taken lightly. And so here's the deal. Oregon has decided that all 27 drugs, the responses from patients are due by April 30th. So at this point, we have 15 days to get a really rapid response in, so that they're actually looking at what patients think and what patients see as affordable and what patients can't live without. These drugs are serious. So I'm going to have Madonna talk more about how we think you should, provide input, but I just want to give you a quick overview. If you haven't looked at the actual list of what they're asking. So dosage and frequency, name of the drug, where you're taking the drug, how long have you been taking it? What's your most recent out-of-pocket cost for this drug? Well, that is going to vary tremendously. Um, is this the preferred drug? Preferred by who? By your doctor? By your insurance company? By you? Um, it's a yes, no. So there's really, I mean, it's kind of confusing. How does the drug help? It, again, this is not how they should be looking at this. Oh, sorry. And then they get into what's your income? Um, they don't need to know this. Um, be really, really careful. So we have some suggestions on how we think you should handle the patient information that they're looking for, and I'm going to let Madonna lead that up, but it's not by starting here. So, and Madonna, I didn't introduce you, so I will let you introduce yourself and let you start with how we suggest that patients get started to provide information to Oregon. So,
Awesome. Well, thank you very much. Can you hear me?
yep.
Okay, good, because I have my uh, handy dandy headphones and I'm never sure if anyone can hear me. So many of you I've seen on the list here, I know you, but my name is Madonna McGuire Smith, and I'm the Executive Director of Pacific Northwest Bleeding Disorders. And we represent patients in Oregon and Southwest Washington who live with a bleeding disorder. And it's a pretty big number, it's 750 families. So if you multiply that times four, that's a pretty large number of people that are impacted by bleeding disorders. Um, we have learned, and many of you probably know about the blood crisis that happened in the 80s and 90s, and our voice was a big part of what helped us get through that whole crisis because we were directly affected by the HIV and AIDS crisis of that time and the Hep C. So patient voice is really important to our community, incredibly important, and so we encourage it all the time. We have active participation all the time by our individuals. We have trained advocates statewide and nationally. So I think the biggest point of my presentation today is just the patient voice is so important. It does make an impact and it does change things. A lot of people think, oh, well, I'll just let somebody else talk for me. And it's like, no, if you really want to make a change, if you really know that this is impacting you, then you need to make it be known. One of the things that um, I want to make clear is that there are no bleeding disorder drugs on that list. So our community is not going to be, at least at this point, directly impacted by the decisions made by the PDAB. However, all of our patients have comorbidities. So many of the people that I represent aren't just in our community, they're in other communities like MS and diabetes and um, arthritis and all of those other communities. So I think we all need to act as one patient community, whether our drug is on that list or not. There could be a different drug on that list that someone in our family or our community uses. So I just wanted to start out by saying that. And then next, I want to say that we're encouraging that there's a group out there called the Patient Inclusion Council. They do excellent work, and I'm going to invite Vanessa, who's with us, to speak in a little bit. But one of the things that we're encouraging you to do is first go to the PIC website. And it says join PIC, but it doesn't mean that you're going to become a member of their community and you're going to hear from them and they're going to have you be yet another organization that you have to be involved in. Instead, it just helps us bring together a larger voice or a larger community. So instead of us being, the breast cancer community and the bleeding disorder community and the whatever MS community, now we're going to be a bigger community of all of our voices together. It helps us just to understand a little bit more about where you're coming from, why you want to be connected to this, and also potentially for organizations that are not yet part of the Patient Inclusion Council. If you go to the PIC and you answer the questions and say that you're part of a local kidney organization that is not yet aware of the Patient Inclusion Council, this gives us a chance to reach out to them as well and bring them into our broader community. So I think this just gives us a chance to join our voices together. So we're asking that you start here. There's a website there that you can see, it's on the screen. And I don't know if maybe Lauren or Vanessa wants to type that also into the chat. That would be great, so that if people wanted to go right to that as well. But it gives you an opportunity to then answer just a few questions. They will lead you directly to the Oregon PDAB list that Lauren just had on the screen. So it's really that survey that we're going to lead you to. So we ask that you go to the PIC webpage, which will then lead you to the PDAB webpage to allow you to answer those questions. But it gives us a chance to bring you into the bigger voice. Also, there's an opportunity for you to speak to the Oregon PDAB directly. So you can request to get onto their meetings. I think it's too late for this month. I think we're scheduled for April 16th, which doesn't give you enough time. You had to have been on by this morning, I think, 48
Actually,
hours.
Madonna, that's for written.
Oh,
Verbal is 24, so you still have time to sign
you're
up
right.
for your verbal comment. Yep.
You're absolutely right, Lauren. I forgot that. So the meeting in April is the 16th of April, and you can go to the PDAB website. There's also the 21st is probably the one that you can be most prepared for. Get onto the public comment on May 21st. We're also not just asking individuals, but if you're an organization, you can also speak publicly because you're going to represent a much larger community of people as well. So fortunately, Lauren has a number of times spoken on behalf of those with chronic disease, and we appreciate you, Lauren, and you, Sarah, for all of your hard work on all of this. But I think the biggest part of my message is just be heard. Don't be afraid to speak out. You're not going to say anything wrong. We're going to be behind you, but joining your voice to a bigger community makes us all stronger and louder, if that makes sense. I think there's one more slide that talks a little bit about talking to our elected officials. So we do know that some of our elected officials are not all that happy with the Oregon PDAB and the way that things are going. So feel free to reach out to your legislator if you haven't already. That's always encouraged. There is a lobby day next week on the 22nd. I know there's a bunch of us that will be there. There have been a series of lobby days in the past. If you're doing a lobby day, maybe when it's time to offer comments a little bit later or questions, you can share with us if you're going to be in the Capitol for some reason and would like to bring up some of these comments. But we certainly encourage you, whenever possible, to talk to legislators either in their district or in the Capitol, but to also just get involved in the larger group so that we can all have one voice. I think that about does it for me. To you, Lauren.
Great. Thanks, Madonna. So I put a couple additional links here. We will send this out so that everybody has this information. Definitely gonna take some questions. Have Vanessa talk a
Oh,
little
I
bit
totally
more.
forgot Vanessa. I'm so
Yeah.
sorry, Vanessa. I said I was going to call you, then I forgot.
I will
No worries.
definitely I'll have Vanessa talk, and then we'll take some more questions. And but the main thing is like May 21st. So I wrote when the patient survey came out, it says it's for patient advocates, but there's no place for patient advocates to actually respond to it. So I wrote Ralph McGresh and asked him how we are supposed to respond to that. And he told me that May 21st was our day. So I would like that we get so many organizations calling in and writing in on May 21st that they have to spend the entire 3 hours listening to us. So I would like challenging everybody to make that a goal that let's get it out there. So Vanessa and then Jaslyn, I'm going to call on you next. So thanks. Welcome, Vanessa.
Thank you so much, and thank you both for having me and for introducing the PIC, which is short for the Patient Inclusion Council. My name is Vanessa Lathan, and I am the new, as of today, lead for the Patient Inclusion Council, which is the part of a larger coalition, which stands for Ensuring Access Through Collaborative Health, which is a national network of patient organizations and allied groups, inclusive of all health condition, disability, and chronic illnesses. And the PIC portion of that is a peer-led, patient-led coalition that provides advocacy support to patients and caregivers throughout the year. And I thank you. And I wanted to highlight, I did drop the link in the chat. We have like a homepage link, and then we have a link directly that we would like patients to sign up as we provide assistance with linking patients and caregivers to the Oregon PDAB survey. And just as been stated, just wanted to share some other things that would benefit patients going through us. We provide tailored support throughout the process. If they have any questions around answering the survey, maybe they feel uncomfortable, maybe they're hesitant. We also will send reminders to make sure that they complete the survey by the 30th. In addition, we will also provide other opportunities to get involved with peer advocacy and caregiver work. And this also takes a burden off of other patient organizations. We're kind of handling the administrative burden with kind of walking patients through the process of completing the Oregon PDAB survey and looking at this as kind of a warm handoff or a soft touch point. So if you know any patients, any caregivers in the state of Oregon, we want to include all voices, all people. Please send them to the link. We want to make sure we're using eachpic.org/pic.voices. And I'll also drop it in the chat again. And if you have any questions, please feel free to reach out to me, as I am the new lead for the PIC and will be fielding any questions. And we really look forward to our continued partnership and getting as many patients and caregivers to complete the survey. And I know also Mark and Tiffany are on, so if there's anything I forgot, I will yield the floor to allow them to jump in.
Thanks, Vanessa. Very, very well said. And again, I'm just going to say you don't need to be from Oregon, because they're listening, and we only have 4 million people in our state. So if you take those 27 drugs and you look at how many people that are actually taking them, I think we need other states weighing in so that they hear from everybody. Jaslyn, question.
Yes, thank you so much for hosting this conversation today and for the presentation. I was really surprised to hear that PDABs are utilizing the QALYs approach and then the EB-LYG approach. I remember, as you mentioned, in COVID time in 2020 or so, when we were having discussions over who should get ventilators, this was a huge thing that the disability community was really elevating, a huge concern. So I'm really just shocked that this is something that's reapproaching again. And the first thing that comes to my mind with this is just the disinformation that could come out of what drugs are effective for certain communities, which are not. Do you have any additional thoughts on how this trend might play out in terms of other ways that it might impact the patient community?
Well, you mean in terms of outside of the Oregon PDAB?
Yes, I'm just thinking in terms of if this becomes a trend of states taking on this practice and then sharing false information, what might happen as a result?
Yeah, I mean, because you're really getting to the crux of why we want this federal legislation that extends the bar on the use of QALYs and similar measures across programs, so you already see it at the VA, right? The VA has a partnership with ICER where they use their studies to inform the formulary at the VA, which, as we all know, is difficult to say the least for veterans. We are also seeing this as a concern, not just in the PDAB capacity, but at P&T committees and drug utilization review boards. So, and actually, when Oklahoma passed their QALY ban, it was because their drug utilization review board had used QALY-based studies to impose prior authorization on certain conditions. And it came to the attention of the legislature, and therefore the legislature advanced this quality ban to keep them from doing that again. So you do see this, I think, and it's not just, some people think it's just a drug issue. It's actually not. One of the communities that's been also very active in this has been the autistic self-advocate community. They've also taken issue with the use of quality adjusted life years. There's a few studies that have been done by the NIH around that look at quality adjusted life years in terms of how you prioritize services just more broadly outside of the drug space. I think we just talk about it a lot in the drug space because ICER has there's so much investment in ICER. They have so much money. They're getting a ton of money from an entity called Arnold Ventures. So we're seeing it more publicly and broadly in the drug space, but that doesn't mean that it's not happening elsewhere. And I think in large part, we're seeing it in the context, though, of Medicaid, more than Medicare.
That's helpful. Thank you.
Yeah.
Yeah, it was huge in Oregon. I mean, it took us 10 years to get all the restrictions off the hepatitis C cure. 10 years of advocacy of going to meetings every 2 months to get rid of all the restrictions that were in place because of it. And now they're redoing their entire drug list. They have to get rid of their prioritized list that they do have, and they have to review every single disease and drug. It's going to be quite interesting.
Yeah,
I don't
it
know
will
how
be. I'm very
Yeah.
eager. Probably our next webinar is going to be about that, right?
Yeah. And by the way, if any of you are not signed up to get messages from the Health Evidence Review Commission in Oregon, they are holding listening sessions now because of us, because of our advocacy. And they just announced another listening session to talk about the new list and how they're going to do that. And so if you're interested at all, sign up because it's really they've listened to us way more than the PDAB. So any other questions from folks? Thoughts, comments? Vanessa, anything? Tiffany, anything we missed? Or Mark?
So Lauren, just to your point about the HERC, I do think it's an important point that the HERC, which had been sort of the bad actor when it came to qualities, has actually been pretty good since the law passed barring qualities and similar measures. And so that's another interesting point to me in Oregon is that the HERC seems to be on a pretty good path where they're doing some meaningful real engagement and trying to do better. And it's just very different than what we are seeing coming out of the PDAB. Just the attitude towards patients and people with disabilities, the engagement process, and not pushing back on the concerns around these qualities and similar measures.
Yeah, so again, and really important just to encourage as many patients as possible to fill these out because they tend to not listen to patient advocacy organizations here. They want to hear from patients. So I know there's a lot of patient advocacy organizations on here, and we just need to really get the word out. And I'm saying do not limit it to Oregonians, please. Tiffany, I see you jumped on.
I did. Thank you. I just wanted to add, since the link was on the slide about the PIC, it had a /survey, and I just wanted to clarify for those on here that that is not the link to the Oregon PDAB survey. That is the link to the Patient Inclusion Council and Ensuring Access Through Collaborative Health. Very in-depth survey that Lauren and Madonna and Sarah all were part of the original pilot that went out last year. It was so successful, and we got funding to go ahead and relaunch it. So we did some tweaks to it. It just went out last week. So our goal for sending people to that PIC form is to get first for the Oregon survey so we can capture them. If we send them directly to the Oregon survey, then we don't know whatever happened with them. But if we can get them to that survey, then we can immediately reply with the Oregon survey, ask them if they completed it, what'd you think of it? Like what Lauren pointed out, all of the questions that are almost impossible to answer, we get their feedback, then we can have them tell the Oregon PDAB, and then we can connect them to our survey that will actually gain context of the affordability and unaffordability whys that are missing in the others. So I just wanted to throw that out as well, since it was an extra link on what that meant.
Thank you. Any other thoughts or questions? Again, let's challenge all the organizations to weigh in on May 21st, because this is our opportunity, because we really can't fill out that survey very well. There's really nothing we can answer on it because we're not on the drugs. So, unless we are, some of us might be. But again, let's make sure that they hear from us, and that you register 48 hours in advance for writing in. And you can register 24 hours in advance for making public comment, but make sure you register to talk. Don't just register for the meeting, because if you don't register to talk and you only register for the meeting, you don't get to talk. So you have to do both. So make sure that you're registered for public comment. I've made that mistake in the past where I thought I was registered for the meeting only, which is listen in. So yeah, it's pretty much listen in anyways. All right, great. Well, I hope you all learned something, and please share this. I will send out the link to everybody that's registered here, and to the recording of it, and I'll put it up on our websites. And just please, let's get it out there, and let's get patients filling out this survey, because if they don't hear from patients, they're just going to go ahead and do it. They don't care. They're just going to, this is their check box. They've checked the box at the end of this month. I don't know if we're going to get them to open it back up. So this is the time. And I know that everyone is reeling from all the changes that are happening all over the country, and this is probably not the top of everyone's mind, but it's super important, because of their timing. It's important that we elevate it, and maybe it's something else they can think about.
And I really do think Chair Bailey is interested in hearing. I really feel like he really wants to hear from us. I don't know that everyone associated with the PDAB is as open, but I feel like this is our chance to get her to hear us, and may make a difference. So
Agreed.
it's important.
Agreed. Shelley does want to hear from us. Yeah. And there's a few others on there that are listening, and listen and pay attention. And actually, will respond. So absolutely really important. Thanks, Madonna. Any other final thoughts, Sarah or Madonna? Okay. Well, I know it's a busy time for everybody. Thank you for coming. Thanks for sharing. And let's get those patient voices heard all over the place.